Hi, my name is Donna Edwards, and today we're going to be discussing medications for opiate use disorder. Introduction to medication for opiate use disorder treatment. Introduction, our nation faces a crisis of overdose deaths from opiates, including heroin, illicit fentanyl, and prescription opiates. These deaths represent a mere fraction of the total number of Americans harmed by opiate misuse and addiction. Many Americans now suffer daily from the chronic medical illness called opiate addiction or OUD. Healthcare professionals, treatment providers, and policymakers have a responsibility to expand access to evidence-based, effective care for people with OUD. Here is an introduction to medication for opiate use disorder treatment. The estimate cost of the opiate epidemic was $504 billion in 2015. An estimate 1.7 million Americans have OUD related to opiate painkillers. 526,000 have heroin related OUD. The World Health Care Organization, whose principles of good care for chronic disease can guide OUD care, development a treatment partnership with patients. Focus on patients' concerns and priorities. Support patient self-management of illnesses. Use the 5 A's at every visit. Assess, advise, agree, assist, and arrange. Organize proactive follow-up. Link patients to community resource support. Work as a clinical team. Involve expert patients, peer educators, and support staff in the health facility. Ensure continuity of care. Here are some key terms. Addiction as defined by the American Society of Addiction Medicine, a primary chronic disease of brain reward, motivation, memory, and related circuitry. It is characterized by inability to consistently abstain, impairments in behavioral control, craving, diminished recognition of significant problems with one's behavior and interpersonal relationships, and a dysfunctional emotional response. Like other chronic diseases, addiction often involves cycles of relapse and remission. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition, DSM-5, does not use the term for diagnostic purposes, but it is commonly describes the more severe forms of OUD. Medically supervised withdrawal, formerly called detoxification, using an opiate agonist or an alpha-2 adrenergic agonist if an opiate agonist is not available, in tapering doses or other medication to help a patient discontinue illicit or prescription opiates. Opiate misuse. The use of prescription opiates in any way other than as directed by a prescriber. The use of any opiates in a manner, situation, amount, or frequency that can cause harm to self or others. Opiate receptor agonist, a substance that has the affinity for stimulant psychological actively at the cell receptors in the central nervous system that are normally stimulated by opiates. Opiate receptor full agonist, example, methadone, bind to the opiate receptor and produce actions similar to those produced by endogenous opiate beta-endorphin. Increasing the dose increased the effect. Opiate receptor partial agonists, example given, buprenorphine, bind to the opiate receptor. Unlike with full agonists, increasing their dose may not produce additional effects once they have reached the maximal effect. At low doses, partial agonists may produce effects similar to those of full agonists. Opiate receptor antagonist, a substance that has affinity for opiate receptors in the CNS without producing psychological effects of opiate agonist. Opiate receptor antagonist, example given, naltrexone, can block the effects of the exogenously administered opiates. Opiates, all natural, synthetic, and semi-synthetic substances that have effects similar to morphine. They can be used as medications having such effects. Example given, methadone, buprenorphine, oxycodone. Opiate treatment programs, OTP, an accredited treatment program with SAMHSA certification and Drug Enforcement Administration registration to administer and dispense opiate agonist medications that are approved by the FDA to treat opiate addiction. Currently, these include methadone and buprenorphine products. Other pharmacotherapies such as naltrexone may be provided but are not subject to these regulations. OTPs must provide adequate medical, counseling, vocational, educational, and other assessment and treatment services either on-site or by referral to an outside agency or practitioner through a formal agreement. Relapse, a process in which a person with OUD who has been in remission experiences a return of symptoms or loss of remission. A relapse is different from the return of opiate use, that it involves more than a single incident of use. Relapses occur over a period of time and can be interrupted. Relapse need not to be long-lasting. The TIP uses relapse to describe relapse prevention, a common treatment modality. Remission, a medical term meaning a disappearance of signs and symptoms of the disease. In the DSM-5, it defines remission as present in people who previously met OUD criteria but no longer meet any OUD criteria, with the possible exception of craving. Remission is an essential element of recovery. Return to opiate use. One or more instances of opiate misuse without a return of symptom of OUD. A return to opiate use may lead to relapse. As is true for patients undergoing treatment for any chronic medical condition, patients with OUD should have access to medical, mental health, addiction counseling, and recovery support services that may need to supplement treatment with medication. Medical care should include preventative services and disease management. Patients with OUD who have mental disorders should have access to mental services. Treatment and support services should reflect each patient's individual needs and preferences. Some patients, particularly those with co-occurring disorders, may require these treatments and services to achieve sustained remission and recovery. Here's an overview of medications for OUD. There is no one-size-fits-all approach to OUD treatment. Many people with OUD benefit from treatment with medication for varying lengths of time, including lifelong treatment. Ongoing outpatient medication treatment for OUD is linked to better retention and outcome than treatment without medication. Even so, some people stop using opiates on their own. Others recover through support groups or specialty outpatient or residential treatment with or without medication. Still, FDA-approved medication should be considered and offered to patients with OUD as a part of their treatment. Let's discuss some benefits. There are the 3 FDA-approved medications used to treat OUD, improve patients' health and wellness by reducing or eliminating withdrawal symptoms, methadone, buprenorphine. Bluntly or blocking the effects of illicit opiates, methadone, naloxone, buprenorphine. Reducing or eliminating cravings to use opiates, methadone, naloxone, buprenorphine. Now let's discuss the effectiveness. The science demonstrating the effectiveness of medication for OUD is strong. For example, methadone, extended-release injectable naloxone, and buprenorphine were each found to be more effective in reducing illicit opiate use than no medication in randomized clinical trials, which are the gold standard for demonstrating efficacy in clinical medicine. Methadone and buprenorphine treatments have also been associated with reduced risks of overuse deaths. The definition here of efficacy is the ability of a product to provide a beneficial effect. Here is some information that is helpful for educating patients and their families about OUD. The information is a tool that can help patients make more informed decisions about their care. Let's take a look at medications for opiate use disorder. The prescribing considerations. For methadone, the mechanism of action at the opiates receptor. Methadone is an agonist. The phase of treatment is medically supervised and withdrawal maintenance. The route of administration for methadone is oral. With naloxone, the prescribing considerations, mechanism of action, opiate receptor is an antagonist. The phase of treatment is prevention of relapse to opiate misuse following medically supervised withdrawal. The route of administration for the naloxone is oral, intramuscular, extended release. The prescribing considerations for the buprenorphine, mechanism of action of the opiate receptor, is a partial agonist. The phase of treatment is medically supervised withdrawal maintenance. The route of administration for buprenorphine is sublingual, buccal, subdermal implant, subcutaneous extended release injection. The possible adverse effects of methadone is constipation, hyperhidrosis, respiratory, depression, sedation, QT prolongation, sexual dysfunction, severe hypotension, including orthostatic hypoextension, and syncope, misuse potential, neonatal abstinence syndrome. The possible effects for naloxone is nausea, anxiety, insomnia, precipitated opiate withdrawal, hypotoxicity, vulnerability to opiate overdose, depression, suicidality, muscle cramps, dizziness, syncope, somnolence or sedation, anorexia, decreased appetite or other appetite disorders. When you inject it with the intramuscular, it can cause pain, swelling, induration, including some cases requiring surgical intervention. The possible effects of buprenorphine is constipation, nausea, precipitated opiate withdrawal, excessive sweating, insomnia, pain, peripheral edema, respiratory depression, particularly combined with benzodiazepines or other central nervous system depressants, misuse potential, neonatal abstinence syndrome implant, nerve damage during insertion removal, accidental overdose or misuse if extruded, local migration or protrusion, subcutaneous injection, injection site itching or pain, death from intravenous injection. With methadone, the regulations and availability, it's a Schedule II, only available at federal certified OTPs and the acute inpatient hospital setting for OUD treatment. The regulations and availability for naloxone is not a scheduled medication, not included in OTP regulation, requires prescription, office-based treatments or specialty, substance use treatment programs, including OTPs. The regulations and availability for buprenorphine, it is a Schedule III, requires waiver to prescribe outside OTPs implant. Prescribers must be certified in the Pro-Bupen Risk Evaluation and Mitigation Strategy, REMS. Program providers who wish to insert, remove implants are required to obtain special training and certification in the REMS. Program subcutaneous injection. Healthcare settings and pharmacies must be certified in the sublocade REMS program and only dispense the medication directly to a provider for administration. Introduction to medications for opiate use disorder treatment. This doesn't mean that remission and recovery occur only through medication. Some people achieve remission without OUD medication, just as some people can manage type 2 diabetes with exercise and diet alone. But just as it is inadvisable to deny people with diabetes the medication they need to help manage their illness, it is also not sound medical practice to deny people with OUD access to FDA-approved medications for their illness. Medication for OUD should be successfully integrated with outpatient and residential treatment. Some patients may benefit from different levels of care during the course of their lives. These different levels include outpatient counseling, intensive outpatient treatment, inpatient treatment, or long-term therapeutic communities. Patients receiving treatment in these settings should have access to FDA-approved medications for OUD. Patients treated with OUD medications can benefit from individualized psychosocial supports. These can be offered by patients' healthcare providers in the form of medication management and supervised counseling and/or by other providers offering objective addiction counseling, contingency management, recovery coaching, mental health services, and other services, example giving housing supports that particular patients may need. Expanding access to FDA-approved medications is an important public health strategy. A substantial gap exists between the number of people needing OUD treatment and the capacity to treat those individuals with OUD medication. In 2012, the gap was estimated at nearly 1 million people, with approximately 80% of OTPs nationally operating at 80% capacity or greater. Blue Cross and Blue Shield reported a 493% increase in members diagnosed with OUD from 2010 to 2016, but only 65% increase in the use of medication for OUD. Improving access is critical to closing the wide gap between the need for treatments without OUD medications and the availability of such treatments, given the strong evidence of OUD medications' effectiveness. Methadone. Methadone retains patients in treatment and reduces illicit opiate use more effectively than placebo medically supervised withdrawal or no treatment, as numerous clinical trials and meta-analysis of studies conducted in many countries show higher methadone doses associated with superior outcomes. Given the evidence of methadone's effectiveness, WHO lists it as an essential medication. Methadone treatment has by far the largest, oldest evidence base of all treatment approaches to opiate addiction. Large multi-site longitudinal studies from the world over support methadone maintenance effectiveness. Longitudinal studies have also found that it is associated with reduced risk of overdose-related deaths, reduced risk of HIV and hepatitis C infection, lower rates of cellulitis, lower rates of HIV risk behavior, and a reduce in criminal behavior. Naloxone reduces illicit opiate use and retains patients in treatment more effectively than placebo and no medication, according to the findings from randomized controlled trials. In two groups, random assignment studies of adults who were opiate dependent and involved in the justice system, all participants received a brief counseling and community treatment referrals. One group received no medication, and the other group received naloxone. During the 6-month follow-up period, compared with no medication group, the group that received the medication demonstrated longer time to return to substance use, about 10.5 weeks versus 5 weeks. They also demonstrated a lower rate of return of use, 43% versus 64%. And they demonstrated a higher percentage of negative urine screens, 74% versus 56%. There are two studies comparing naloxone to sublingual buprenorphine. A multi-site randomized trial assigned adult residential treatment patients with OUD to either naloxone or buprenorphine. Patients randomly assigned to buprenorphine had significantly lower relapse rates during 24 weeks of outpatient treatment than patients assigned to naloxone. This finding resulted from challenges in completing naloxone induction, such that a significant portion of patients did not actually receive naloxone. However, when comparing only those patients who started their assigned medication, no significant between groups differences in relapse rates were observed because dose induction was conducted with inpatients. Finding may not be generalized to dose induction in outpatient settings, where most patients initiate treatment. A 12-week trial among adults with opiate dependence in Norway who were opiate abstinent at the time of random assignment were found that naloxone was as effective as buprenorphine in retaining patients in treatment and in reducing illicit opiate use. With oral naloxone is also available, but it has not been found to be superior to placebo or to no medication in clinical trials. Non-adherence limits its use. Buprenorphine, in its sublingual form, retains patients in treatment and reduces illicit opiate use more effectively than placebo. It also reduces HIV risk behaviors. A multi-site randomized trial with individuals addicted to prescription opiates showed that continued buprenorphine was superior to buprenorphine dose taper in reducing illicit opiate use. Another randomized trial showed that continued buprenorphine is improved treatment retention and reduced illicit prescription opiate use compared with buprenorphine dose taper. Long-term studies of buprenorphine show its effectiveness outside of clinical research protocols. Naloxone, a short-acting opiate antagonist, and is also often included in the buprenorphine formulation to help prevent diversion to injected misuse. Because the evidence of buprenorphine's effectiveness, WHO lists it as an essential medication. Buprenorphine is available in transmuscular, example, sublingual, or buccal formulations. Buprenorphine implants can be effective in stable patients. FDA-approved implants, ProBuphine, after a clinical trial showed them to be as effective as relatively low dose, example 8 milligrams or less daily. Sublingual buprenorphine, which is Suboxone equivalents, for patients who are already clinically stable. More research is needed to establish implants' effectiveness outside of research studies, but findings to date are promising. FDA-approved buprenorphine extended-release injection, Sublocade, in November 2017 to treat patients with moderate or severe OUD who have first received treatment with transmuscular buprenorphine for at least 1 week. This buprenorphine formulation is a monthly subcutaneous injection. Cost effectiveness and cost benefits. Cost effectiveness and cost benefit analysis can further our understanding of OUD medications' effectiveness. Data indicate that medications for OUD are cost effective. Cost effectiveness analysis compare the cost of different treatments with their associated outcome. Example given, negative opiate urine test. Such analyses have found that methadone and buprenorphine are more cost effective than OUD treatments without medication. Counseling plus buprenorphine leads to significantly lower healthcare costs than little or no treatment among commercially insured patients with OUD. Treatments with any of the 3 OUD medications in this presentation covers led to lower healthcare usage and cost than treatments without medication in a study conducted in a large health plan. Relatively few cost-benefit analyses have examined addiction treatments with medication separately from addiction treatments in general. Cost-benefit studies compare a treatment cost with its benefits. The treatment is cost beneficial if its benefits outweigh its cost. These benefits can include reduction expenditures because of the decrease in crime, reduction expenditures released in the decrease of use of the justice system, improvement quality of life, reduction of healthcare spending, greater earned income. Methadone treatment and OTPs can reduce justice system and healthcare costs. Requirements and regulations. Following in a summary of regulations and requirements that apply to the 3 OUD medications. Part 3 of my presentation will discuss the pharmacology and dosing of the medications. Only federally certified and accredited OTPs can dispense methadone for the treatment of OUD. Methadone is typically given orally as a liquid. OTPs can dispense buprenorphine under OTP regulations without using a federal waiver. Individual healthcare practitioners can prescribe buprenorphine in any medical setting as long as they apply for the received waivers of the special registration requirements defined in the Controlled Substance Act. Several laws and regulations contain information about which healthcare practitioners are eligible to apply for a waiver and how to qualify. Eligible physicians, nurse practitioners, physician assistants, and other qualifying practitioners, clinical nurses, specialists, certified registered nurses, and anesthesiologists, and certified nurse midwives can apply for a waiver. At present, clinical nurse specialists, certified registered nurses, and anesthesiologists and certified nurses midwives are only eligible to apply for the waiver until October 1st, 2023. Physicians and other qualified providers who are board certified in addiction psychiatry or addiction medicine, or who satisfy additional practice and reporting requirements, may apply to increase their patient limit to 275 after a year at 100 patient limit. Prescribing buprenorphine implants require Bufen REM's program certification. Providers who wish to insert or remove implants must obtain live training and certification in the REM's program. Healthcare setting and pharmacies must get SUBLOCADE REM's program certification to dispense this medication and can only dispense it directly to healthcare providers for subcutaneous administration. Naloxone has no regulations beyond those that apply to any prescription pharmaceutical. Any healthcare provider with prescribing authority, including those participating in OTPs, can prescribe its oral formulation and administer it as long-acting injectable formulation. The Controlled Substance Act contains a few exceptions from the requirement to provide methadone through an OTP or buprenorphine through an OTP or a waiver practitioner. OUD medication treatment limits and reporting requirements. The following websites provide information about the Department of Health and Human Services final rule to increase patient access to medication for OUD and associated reporting requirements. These include 1. Administering, not prescribing, an opiate for no more than 3 days to a patient in acute opiate withdrawal while preparations are made for ongoing care. Number 2, administering opiate medications in a hospital to maintain or detoxify a patient as an incidental adjunction to medical or surgical treatment of conditions other than addiction. Duration of treatment with OUD medication. Patients can take medication for OUD on a short-term or long-term basis. However, patients who discontinue OUD medication generally return to illicit opiate use. Why is this so? Even when discontinuation occurs slowly and carefully, because the more severe form of OUD, example given, addiction, is more than physical dependence. Addiction changes the reward circuitry of the brain, affecting cognition, emotions, and behavior. Providers and their patients should base decisions about discontinuing OUD medication on knowledge of the evidence base for the use of these medications, individualized assessments, and an individualized treatment plan they collaboratively develop and agree upon. Arbitrary time limits on the duration of treatment with OUD medication are inadvisable. Maintenance treatment. The best results occur when a patient receives medication for as long as it provides a benefit. This approach is often called maintenance treatment. Once stabilized on OUD medication, many patients stop using illicit opiates completely. Others continue to use some form but less frequently and in smaller amounts, which reduces their risk to morbidity and overdose death. OUD medication gives people the time and ability to make necessarily life changes associated with long-term remission and recovery. Example given, changing the people, places, and things connected to their drug use, and to do so more safely. Maintenance treatment also minimizes cravings and withdrawal symptoms, and it lets people better manage other aspects of their life, such as parenting, attending school, or working. Time to detox. Medication taper. After some time, patients want to stop opiate agonist therapy for OUD through gradually tapering doses of the medication. Their outcomes will vary based on the factors such as the length of their treatment, abstinence from illicit drugs, financial and social stability, and motivation to discontinue medication. Longitudinal studies show that most patients who try to stop methadone treatment relapse during or after completing the taper. For example, in a large population-based retrospective study, only 13% of patients who tapered from methadone had successful outcomes. No treatment re-entry, death, or opiate-related hospitalization within 18 months after taper. A clinical trial of naloxone versus treatment throughout medication also found increased risk of returning to illicit opiates after discontinuing medication. Adding psychosocial treatments to taper regimens may not significantly improve outcomes compared with remaining on medication. One study randomly assigned participants to methadone maintenance or to 6 months of methadone treatment with a dose taper plus intensive psychosocial treatment. The maintenance group had more days in treatment and lower rates of heroin use and HIV risk behavior at 12-month follow-up. Patients wishing to taper their opiate agonist medication should be offered psychosocial and recovery support services. They should be monitored during and after dose taper, offered naloxone, and encouraged to resume treatment with medication quickly if they return to opiate use. Medically supervised withdrawal is a process in which providers offer methadone or buprenorphine on a short-term basis to reduce physical withdrawal signs and symptoms, formerly called detoxification. This process gradually decreases the dose until the medication is discontinued, typically over a period of days or weeks. Studies show that most patients with OUD who undergo medically supervised withdrawal will start using opiates again and won't continue in recommended care. Psychosocial treatment strategies such as contingency management can reduce dropout from medically supervised withdrawal, opiate use during withdrawal, and opiate use following completion of withdrawal. Medically supervised withdrawal is necessary for patients starting naloxone, which require at least 7 days without short-acting opiates and 10 to 14 days without long-acting opiates. Patients who complete medically supervised withdrawal are at risk for opiate overdose. In the treatment setting, almost all healthcare settings are appropriate for screening and assessing for OUD and offer medication on site or by referral. Settings that offer OUD treatment have expanded from specialty sites, certified OTPs, residential facilities, outpatient addiction treatment programs, and addiction specialist physician offices, to general primary care practices, health centers, emergency departments, inpatient medical and psychiatric units, jails and prisons, and other settings. OUD medication should be available to patients across all settings and all levels of care as a tool for remission and recovery. Because of the strength of the science, in 2016 report from the Surgeon General urged adoption of medication for OUD along with recovery supports and other behavioral health services throughout the healthcare systems. Challenges to expand access to OUD medication. Despite the urgent need for treatment throughout the United States, only about 21.5% of people with OUD received treatments from 2009 to 2013. The Centers of Disease Control and Prevention lists more than 200 U.S. countries as at risk for an HIV or hepatitis C virus outbreak related to injection drug use.